Good morning to everybody, and thank you very much, Dr. Paranagama, for that kind introduction. And before I start my presentation, I would like to just thank Kurunegala Medical Association for giving me this valuable opportunity. Yeah, today I'm going to discuss how to approach for the undiagnosed acute abdominal pain. Yeah, let me to start. And the definition of acute abdomen, very simply, is a sudden onset of abdominal pain which need urgent investigation and treatment. That's a very simple definition. There are a lot of complicated definitions, but we'll go by this simple definition. Right. As you know, and most of the surgical emergencies we get are due to acute abdomen. When you get such a patient, it's very difficult to diagnose. That is really challenging to the surgeon. It's like I just get into the dark room without a light. You don't know where the chair is, you don't know where the cupboard and the bed and so on. It's our duty to see where the chair, where the bed and so on. So it's very difficult task. So it's really challenging to the surgeons. That's why it's called black hole in surgery. Acute abdomen is a black hole in the surgery. It's very difficult task. When you get a patient with acute abdomen, there will be a lot of differential diagnoses come to our mind. So what we have to do, we have to narrow down those differential diagnoses or shortlist the differential diagnosis, for which we have to have some form of systematic approach. If you don't have systematic approach, we are just handling the patient without proper idea. How are we going to have the systematic approach to the acute abdominal patient? That's not a magical thing. This is very simple. So right from the medical student day, we study the history, examination, and investigation. Same way here. So we can have an accurate history. Accurate history should be really accurate, not just abdominal pain. You know, when we do the ward round, most of the house officers says, so this patient presented abdominal pain. That doesn't mean any sense. Right? We can't come to a diagnosis. In this case, there should be accurate history and thorough examination and focus investigation. Most of the time, we do some investigation for the sake of doing, not that. So we have to have some differential diagnosis keep in our mind and have it that in mind, and we have to devise our investigations. This assessment process should be really precise. That is because sometimes we get very bad patients. They will end up with a real, difficult scenario. Some of the patients might lead to the severe morbidity and mortality. So because of that, our assessment should be very precise. You know, and sometimes we get some patients with acute abdomen who need urgent intervention and as well as assessment. So as example, and perforated viscus and the ruptured abdominal aortic aneurysm. In the meantime, sometimes we get some patient, they come with a severe abdominal pain. When you see the patient, this is really exciting. It's exciting. But they might have ureteric colic, they need only simple analgesics. We can leisurely investigate the patient. So that is why our assessment process should be very precise. History examination is very important things. Before I just approach to the patient with acute abdomen, I would like to highlight a couple of facts in related to the physiology and the anatomy. We have to have very good knowledge about the pain physiology. When we talk about the abdominal pain, we just have three types of abdominal pain. There's a visceral pain, and the parietal pain, and referred pain, and at the corner, the non-surgical abdominal pain. These things we have to keep in our mind when you are assessing the patient with acute abdomen. What is visceral pain? It's simply the visceral pain is due to irritation of the visceral peritoneum. In that case, we get gradual onset of very poorly localized pain in the abdomen. It's very difficult to diagnose because they come with, very vague pain, right? So I will explain to you why do you get a very vague pain in visceral pain. So what are the causes for visceral pain? So usually the visceral pain could be due to distension of the whole organ, like in intestinal obstruction, all right? And as well as spasm of the muscles. Most of the time we get the severe visceral pain due to spasm of the muscles. As example, we can say the ureteric colic, right? And intestinal colic, enteritis, and so on. In the meantime, sometimes it could be due to the obstruction of the hollow organ, like again, ureter and the intestine. It's very importantly, the visceral pain is most of the time associated with autonomic symptoms like nausea and vomiting. Then what is parietal pain? The parietal pain is due to the irritation of the parietal peritoneum. The parietal pain is very precise, right? Very localized, not like in visceral pain. That is because the nerve supply to the parietal peritoneum almost similar to the abdominal wall. It follows the same dermatomal distribution. That is why it's very precise. I will just touch on the little bit of embryology and anatomy of the pain. You see, at the beginning, when we, and that's mean at the beginning, the sense when we are fetus, in the fetus, the abdominal cavity is just like a big balloon lined by the simple squamous epithelium, which is called mesothelium. So, which time, what could happen? This gut tube will push into this the peritoneal cavity and taking the blood supply and the nerve supply with them. So either side of the blood supply and the nerves, there will be another two peritoneal fold. So collectively, these two peritoneal fold and the blood and the nerve bundle called mesentery. Though the peritoneal lining is a continuous lining, at the different part, we give them different name. When the peritoneum is lining the visceral organ, we call it visceral peritoneum. When it's lining the abdominal wall, inside the abdominal wall, we call it as the parietal peritoneum, right? The mesentery is it's like a sandwich layer, right? Double layer of the visceral peritoneum is called mesentery, right? So all the organs within the peritoneal cavity lined by the viscera, when they get stimulated, their pain will represent at the anterior abdominal wall. Whereas the organs behind the peritoneum, that's a retroperitoneal organ, the pain arising from the retroperitoneal organs will reflect at the back. As example, kidney and the pancreas. All right. The fetal gut is a single tube. With time, there will be some part of the gut will be distended, some part will be there folded and twisted and so on. However, ultimately, this gut tube can be divided to three main segments. Those are not anatomical division. Basically, for our study purpose, we can divide. That is foregut, midgut, and the hindgut. The pain arising from the foregut will represent as the epigastric region. The pain arising from the midgut will represent as the periumbilical region. And lastly, the hindgut pain will be represented as the suprapubic or otherwise hypogastric region. Right? I think this is very important for us to assess the patient when they come with the abdominal pain. One of the classical textbook example to explain the visceral pain and the somatic pain is the parietal pain is the acute abdomen, acute appendicitis. In acute appendicitis, appendix will be inflamed. Appendix is a midgut structure. Being a midgut structure, especially the first pain, that's a visceral pain, will be reflected at the periumbilical region. You know, at the beginning, there will be a spasm of the appendicular wall muscles, and there will be distension. With all these things, the nerve fibers will be triggered. That nerve will that pain will be represented at the periumbilical region. Once the inflammation just spread to the parietal peritoneum, the pain will be very localized to the right iliac fossa. So that's how in appendicitis patient, initial pain get at the periumbilical region, then later on it shifts to the right iliac fossa. One thing we have to remember, all the patients won't come with this classical pain cascade. Right? Some of the patients come with the diffuse abdominal pain. Start with the diffuse abdominal pain, then that will shift to the right iliac fossa. But this is basically just to study purpose. Only about 50%, roughly about 50% of people will come with this classical migrating type of patient. I think now you got a rough idea about what is visceral pain, what is parietal pain. The third one is referred pain. The referred pain is a result of adjacent embryological structures that subsequently migrate away from each other. But the dermatomal, the nerve supply is sharing. Though they separate, they are sharing the dermatomes. That is why they get referred pain. The lastly, but not least, abdominal could be due to non-surgical things that you have to keep in your mind. And a couple of examples I have given here. Sometimes the diabetic patients, the ketoacidosis patients, they might come with abdominal pain, diffuse abdominal pain. If we don't keep that in our mind, we might misdiagnose the patient. In the meantime, a zoster, right? They will get neuralgic pain on the one side, along the distribution of a particular nerve. So we try to find the cause for the abdominal pain. We can't, because at the beginning there won't be blisters, right? So, but these things we have to keep in our mind. Another two examples I can give it to you all. That's MI, especially the MI patients can come with the upper abdominal pain and lobar pneumonia. So those things we have to keep in mind when you're assessing the patient with the acute abdomen. Right. Now I have given you the brief explanation about the pain in an acute abdominal patient. So then, how are we going to formulate some sort of a strategy to diagnose this patient? That's the main challenge. Yeah. So the differential diagnosis could be made based on the pathology of the disease. Some of the consultants go by this. So whether it's inflammatory nature, and whether it's a perforated viscous, obstruction of the tubing system, or any sort of ischemia or bleeding. But with that, I think it's very difficult to come to a diagnosis. Other set of the clinicians, they go by system-wise, whether it's a gastrointestinal system, renal or urology, and the vascular or gynecology. I think this is much more easier than the previous one. Right. Having that back in our mind, we'll get into the assessment of the patient. At the beginning, I told you all, and so the assessment based on the history, examination, and investigation. Right. When you get a patient with acute abdomen, first thing is we have to see whether this patient is stable or not. Don't jump and go and ask the patient's history if the patient is not stable. In the meantime, the patient should be pain-free. If the patient in pain, when you ask the patient's history, he will say something, right? Because he's pain. He need to have his pain to get controlled. So first of all, see whether your patient is stable or not. If the patient is stable, we go by the history examination, investigation, I explained to you. If the patient is not stable, assess the patient in terms of ABC, that's usual pattern, air, breathing, circulation, then dysfunction, and so on. And in the meantime, you can resuscitate the patient. And please make sure to give some painkillers to keep the patient comfortable. So while you are just resuscitating the patient, you may get the history and do the examination simultaneously. In the history, in acute abdominal patient, these are the couple of things very important to ask: onset, progression, duration, associated symptoms, and the risk factors. Whereas there's a very famous mnemonic called Socrates. That's mean site, onset, character, radiation, alleviating factors. That's mean anything make the patient's condition worse or better, on the time, and exacerbating factors and the severity. And for medical students, and this is one of the famous way to assess the patient, right? The associating factors are very important. So see whether the patient having fever. If the patient having fever, whether it's a chills with the chills and rigors. What do you mean by the chills and rigors? If the patient's having fever with chills and rigors, that's when the patient has high fever, right? So appendicitis patient won't come with a high fever. If you have a patient with a right iliac fossa pain, the patient having fever with chills and rigors, this is something else. Unless ruptured appendix, it can't be simple appendicitis, right? And see whether the patient has cough and shortness of breath. In that case, your diagnosis may be extra abdominal things like pneumonia, all right? And especially in the low abdominal pain patient, you have to ask full history regarding the gynecological history, right? And the vaginal bleeding and discharge, and whether the patient's having some sexual disorders and so on. Especially in female, if you don't ask the last menstrual periods, actually that's a really, it's a crime, right? If you miss last menstrual period, and sometimes patients might come with the ectopic pregnancy. Sometimes we might send the patient to you all saying that's something else, but it's a house officer's duty to get the full history. I'll give one good example. And when I was SR, and there was one patient admitted to the Profit Colombo. That patient was seen by the professor of gynecologist, and in the evening, but in the night, the patient got admitted to the professor in surgical unit with abdominal pain. That was somewhere around 1 a.m. The nurses called house officer, and the house officer was told that this patient has been seen by the professor of gynecologist, and he's having low abdominal pain. Then the house officer response was, okay, if sir has seen, the worst thing is ectopic, but in that case, I don't have to come and see this patient again. It could be appendicitis or something. I'll come and see the patient next day morning. By the time the HO, house officer, come to see the patient's prognosis. The patient died with ectopic. That is why, though we have seen, because by the time we assess the patient's different scenario, but these all medical things are dynamic, not static. So the next person should see the patient, get the proper history and do the examination. Don't depend on the others. Anyway, it's very important to get the gynecological history when the patient's having a low abdominal pain. The other thing is, especially in endometriosis, you have to depend on the history, I suppose, because they are having dyspareunia, dysmenorrhea, and menorrhagia. When you do the blood test, may be normal. Ultrasound scan, unless patient having chocolate cyst, ultrasound normal. Then the people say this is not a gynecological. Actually, it's gynecological. If you go by the history, you can say. Then do the vaginal examination. If there's the tenderness on vaginal examination, so that's quite sure it's endometriosis, or sometimes it could be PID, right? So history is the key point in diagnosing acute abdominal. The loss of appetite and loss of weight is very important. That's actually important in chronic abdominal pain patient, not in the acute abdominal pain. But you can't neglect it. Say, when do you get loss of appetite and loss of weight? Mainly, not only in malignancy, mainly in malignancy. So the patients who have chronic abdominal pain might have loss of weight and loss of appetite. So that means probably malignant. This patient can present as acute abdomen. How? The sigmoid tumor got obstructed, right? So then you can have a rough idea, oh, this patient's having all the features of intestinal obstruction. But pathology could be malignancy because he has loss of appetite and loss of weight. Even before surgery, you can have a rough idea about the complete diagnosis. All right. The past medical history, family history, social history, and drug history is very important. I'll touch everything one by one. Yeah? I have just elaborated the importance of asking the menstrual history. Right. Having all this in our mind, we'll just discuss each point one by one. I'll run very quickly. Yeah. How does the age and sex contribute to your diagnosis? Supposing that For patients come with a colic abdominal pain, the patient age is 6 years. And there's another patients come with a colic abdominal pain, age is 60. Do you think that the diagnosis is the same? No. In colic abdominal pain in kids could be interoception, right? In old age, it could be due to intestinal obstruction due to malignancy or something. So that is why age is very important. When you are present, especially junior doctors, when you are present in your history to the seniors, you have to mention that this. So we got a 6 years old boy came with an intestinal obstruction. So the colic abdominal pain. So then the diagnosis is different. So age is very important. It's quite obvious that the sex is another important factor. Again, if somebody comes with a right low abdominal pain, which is sudden onset, this is a female patient. 28 years old female patients come with the sudden onset of right low abdominal pain. What is the more dangerous thing? You have to exclude ectopic by asking period of amenorrhea. But period of amenorrhea don't depend entirely on that. When I was in Anuradhapura, I got one patient. Actually, she had a POA, 3 months POA. 3 months POA. And that patient has been, the patient originally from Negombo, she has come for something else to the Anuradhapura. But as patient developed pain, she came to me in the private sector. She has been seen by 2 gynecologists because of the 3 months of POA. So then, by history, 2-3 gynecologists see, and the POA 3 months, a couple of ultrasounds done, it's CG negative. So whatever is then done, that was the last patient to me, and I call my colleague, consultant radiologist. I said that because this is my last patient, can you kindly just do this patient's ultrasound scan quickly so that I can go? And having said that, I just went to the analyst room, and they are actually, one of my colleague gynecologists was also there. And the radiologist called me saying that this patient is having ruptured ectopic. See, POA 3 months, HCG is negative, a couple of ultrasounds done. This is not anybody's fault. This could happen. That is why don't rely on the other things. You examine yourself. Right? Ultimately, patients came to us, patient collapsed then and there. So after that, my colleague gynecologist, he asked me to admit this patient straight away to the ward, and they did this. So because of that, if the patient's female is in reproductive age, come with the low abdominal pain, don't just consider as a UTI or appendicitis and so on. Please try to exclude ectopic. I think what you could do, simple HCG. That can be done at the A&E level, right? At the admission itself. Right. Site. That is, we'll get into the Socrates site. Site is very important. We always try to relate our diagnosis when the patient pointed somewhere to the underlying structure. So patients come with the right upper abdominal pain. What are the structures there? Liver, gallbladder, and the hepatic flexure. Usually we try to relate to that. But in addition to that, as I mentioned earlier, maybe lobar pneumonia, right side basal pneumonia. All right. The site is very important. So normally, the foregut pain will represent at the epigastric region. So that also we can divide into the 9 quadrant, which we learn at the medical student days. The right upper abdomen, that right hypochondriac. The possible causes are gallbladder disease, liver disease, and the hepatic flexure. The epigastric region, stomach, pancreas, and sometimes liver, because liver is also crossing. The liver and the very rarely and the gallbladder. Left side, left hypochondriac region, the disease related to the spleen and the splenic flexure, right? The central area, that's umbilical region. Most of the time, the pathology related to the intestine, basically small intestine. Either side of the umbilical regions, we are having lumbar region, again kidney and ureter and intestine. Right? So on, you can go by that. Always, when the juniors present the case, as I mentioned earlier, don't say these patients came with a abdominal pain. Just tell us, these patients came with the epigastric pain for 2 days or like that. These patients came with the suprapubic pain. Otherwise, if you just say patients came with abdominal pain, we are nowhere. All right. So site is very important. Onset. There's another important fact. Whether it's a sudden onset or gradual onset. You know, all the inflammatory diseases are gradual onset. All the itis, inflammations, appendicitis, pancreatitis, cholecystitis, diverticulitis, all itis is a gradual. They start with a gradually, then it's gone, getting worse with time. If it's a sudden onset, what are the possible things? Yeah, it may be ruptured ectopic, ruptured viscous, duodenal rupture, right? If you are a very good history-taking person, you can ask, is it a sudden onset, but gradual onset? Other thing is twisting things. The twisted ovarian cyst, the twisting of the testis, that's a testicular torsion. Those are sudden onset, right? So it's very important to know whether the pain is sudden or gradual onset pain. The character. I know that various textbooks explain there's a burning nature, stabbing nature, and so on, but I don't think we can come to a diagnosis with that. In my case, when I get a patient, I used to define 3 types of pain in regards to abdominal pain. That's continuous pain. All continuous pain are inflammatory in nature or ischemic in nature, right? Just say when you get a patient with a twisted ovarian cyst, the patient will sudden onset pain. After that, what could happen to the cyst? Ischemic. After that, that pain will be continuous. Right? Generally, because there's no hard and fast thing is medicine. Generally, all inflammatory pains are continuous or ischemic pains are continuous. What is colicky pain? Colicky. There are 2 organs which give rise colicky pain. What is that? Intestine. Whether it's a small intestine or large intestine. And then those are the 2 main organs which give rise colicky pain. Right? Then colics. There are 2 colics, biliary colics, and then ureteric pain. So for my diagnosis purpose, I used to follow these 3 types of pain. Right? The patient having colicky abdominal pain, I know that if it's a male, probably this patient's pain arising from the intestine. If the colics comes very frequently, it could be comes from the small intestine. If it's little, if there's a little time apart 2 pains, it could be from right? The stomach won't give rise to colics. The colics always start after the right. So character is very important. So I don't follow the textbooks. This is for me. So then you can decide what to follow. Other thing is the radiation. Radiation is very important. Say ureteric colic. This colic, the colic is colic. Ureteric colic, patient get underlying pain radiated down to the stomach.
And they have high fever more than
aggravating factors and worsening factors. So we have to ask what could aggravate your pain? What could relieve your pain?
Now,
we'll just take an example. Patients come with epigastric pain, which is gradually onset. So you have to think in terms of stomach and the pancreas. If it's a stomach, when the patient
and the serum
takes
creatinine
meal,
was 1,000
when do you get the
micrograms.
pain?
Remember, the serum creatinine is a
Because when you get the meal, that meal
even
will
with
get into
sepsis,
the
you can
stomach.
get hydrating liver.
After a couple of minutes. But if the patient says, my pain gets worse after a couple of hours after the meal,
so we repeat this
one and a half hours.
So the serum, high serum for
Maybe from the gallbladder, maybe
sepsis. So bone marrow
pancreas, because those things should get stimulated. Right? The pancreas and the gallbladder will get stimulated once the things get to the duodenum. Just after the meal won't come to the duodenum.
Recovering.
Right?
Dengue,
so this is very important. That's
so
why
later
we
we
need to
reveal
ask
that
very precise.
And it shows
The patient develop pain
pseudomonas septicemia. We have
after about
initiated
1.5 hours, which is
disease
colic in nature.
and continued for 7 days, and patient was discharged in stable
Abdominal
condition.
angina.
In
Right?
this case,
The abdominal
it
angina,
the importance of
once the food comes to the small intestine for the digestion and the absorption, there should be more blood diverted to the intestine. But the blood can't divert to the mucosal area because there's a narrowing. Right?
All this
so those patients get pain a couple of hours after the meal. That is very important to us. That is why I'm saying that no point just saying that this patient pain get worse after me.
So in the
We don't know whether it's a stomach problem, gallbladder, pancreatic, or intestine.
There are many emerging
So, worsening
cases.
factors as
So
well as relieving factors. And very famous is pancreatitis. Their pain get relieved when they bend forward. That is because the inflamed organs in the retrograde. So when you lie down or the bowel will fall on the there is some pressure on it. But when they bend forward, then everything will come out from the pancreatic pain. That is why they are having a more comfortable life when they bend.
Respiratory distress syndrome and myocarditis.
Right. How does the past medical history help us come to the diagnosis?
Management, and these patients
we go one by one. Sorry, past surgeries.
This was such a patient.
So if a patient has a surgical scar on the right iliac fossa, I'm very happy it can't be appendicitis. Very rarely we stump appendicitis, but little unlikely. Right? In the meantime, the patients who are having laparotomy scar, chronic abdominal pain, so this patient might have
broad-spectrum antibiotics and hydrocortisone.
Right.
So
because of that, the prior surgical scar, prior surgical history is very
intravenous.
How can this cardiovascular hypertension and hypertension help you to come to diagnosis in acute abdomen?
He was subsided and she was successfully.
It's very interesting. So if the patient has atrial fibrillation, past history of atrial fibrillation, patient of warfarin,
short-term
comes with the colic abdominal pain. What could it be? Mesenteric infarction, embolization, and block the vessels. So you relate each other.
And now we are moving
because of that part is very, very important. The other thing is, some of the disease comes repeatedly. They present repeatedly. So what sort of pain you had last time? Is it similar to this time? What are the example for the repeated presentation of pancreatitis, diverticulitis, gallstone disease, right, and inflammatory bowel disease. Right. So just get a very good past history.
Mother of a 5-year-old girl who is in
drug history.
second trimester.
How can the drug history help me?
Presented to the
Diagnosis of
outpatient
acute
department.
Say, 70 years old, Achiyamma come to me with epigastric pain. She says the pain gets worse just after the meal.
And
so we have been arthritis for years and years. It's on non-steroid and drugs.
The patient was stable.
Then I have to think more.
So the patient was correctly admitted to the medical ward.
Because of disease. So
in the medical ward,
drug history might help me to come to diagnosis in one way. The other way, drug history is very important for the surgeon because if this patient needs surgical intervention,
And how
we have to know what are the indications on, especially whether the patient on ventilator and
the blood
requiring,
pressure
right?
and the
In
pulse
that case,
pressure
I
was
have to
normal.
take some
So
precautions.
when you are
Otherwise, I
assessing
might end
vital
up with the disease,
parameters in
right?
pregnancy,
So that
you
drug
are
is
know
important.
physical changes in
What about the social history?
pregnancy.
Social history also again important. Say if you are a very alcoholic patients come with epigastric pain and ready to the back and the pain get relieved with the bending forward. It's quite obvious these alcoholic patients might have acute hepatitis. Right? Smokers, right? So social history, not only the diagnosis, the patient condition, in management wise also is very important. Allergic history is quite obvious because when you want to give some medication and when you want to do a contrast studies and so on, the allergic history is very important. So please get a very good history. So good history help you to come to a diagnosis, right? Your differential diagnosis will be shortlisted with your very good history. Then get into the examination. With the proper consent, go for the examination, right? Before your examination, make the patient comfortable. I'll give you another example. If all man come with the acute urinary retention, his bladder is up to the umbilicus, right? I know that chronic retention is not that painful. Somebody can argue with me, but if a patient come with the retention, so you're going to do the rectal examination, right? The patient in some discomfort. I don't think patient will be happy, right? What you could do, get the patient, make him comfortable, give some painkillers, and then later on do the. So likewise, always before getting to the examination, please make the patient comfortable. The patient in pain, use painkillers. Urethric patient, don't go and touch the abdomen unless you are putting some supposition to the backside, right? So always make sure whether your patient is comfortable or not. So then, thereafter, with the proper consent, we can go by the inspection, palpation, percussion, and auscultation. The percussion shouldn't be done if the patient is having tender abdomen, right? Yeah. On examination, the examination, before you get into the proper abdominal examination, always go by the general examination. Okay? See the patient's appearance, facial expression, patient posture, right? This might give some hint for you to diagnose patient abdominal pain. So it's very important to know the patient's appearance, right? Right. Especially the body posture and so on. If the patient is bending forward, as I just discussed a little bit earlier, it could be pancreatitis, right? If the patient is just lie on the bed without moving, oh, maybe patient might have some sort of peritonitis, right? So that will give you some clue. And facial expression is very, very important. After that, before touch the abdomen, go by the vitals, right? Vitals include pulse rate, respiration, blood pressure, and so on. If the patient's having tachycardic, tachypneic, and low blood pressure, the patient may be in shock, maybe hypovolemic or maybe septic, whatever, right? So you address that part before you examine the patient, right? Right. So with all that, if the patient is comfortable, if the patient is stable, we can go by our routine inspection, palpation, and percussion and so on. Inspection. As in our medical student day, inspect, see whether the abdomen distended, whether there's any scars, any other signs. Right? Those things will give you some clue to diagnosis. Right? If everything's okay, and just go by your palpation. Right? Before you start the patient, ask patient which area you get more pain. Right? Don't start at that side, because when you start at that point, thereafter onward, patient in pain. You can't assess the abdomen properly. You start from away from the maximum pain area, right? So be gentle always. It's very important. Sometimes the patient might voluntarily contract the muscles. What is guarding? Guarding is involuntary contraction of the muscles when you touch the abdomen, all right? But sometimes patient might voluntarily guard. then you might mislead. If you think that the patient is guarding voluntarily, what you could do, talk to the patient, right? Deviate the patient mind to somewhere else, right? While you examine. So then you can mix the history and examination together, right? So you can get some more information. In your palpation and look for the tenderness, guarding, and rigidity, and as well as any organomegaly, right? And see whether there's a free fluid in the abdomen. Percussion. So I have highlighted here percussion. Be careful when you do the percussion, especially in acute abdominal pain patient, because if they have peritonitis, you are just making and more uncomfortable to the patient, right? So better avoid percussion. In my case, I don't like to do percussion. Auscultation is very important, especially in bowel obstruction. So you have to listen to the bowel sound. In initial stage, when there's intestinal obstruction, there will be exaggerated bowel sound. That is because when there's obstruction, the proximal part try to expel its content through the obstruction. In that process, there will be exaggeration of the bowel sound. Later on, this man will get man in the sense bowel, right? Get tired. So then that part get paralyzed. So later on, the patient will have absent bowel sound. That is why when somebody present the case, don't say the bowel sound is normal. Bowel sound high. Bowel sound is absent bowel. Like that. Okay. So you can't escape without examining the groin. Right? It's very important. Sometimes patients might have intestinal features of all the features of intestinal obstruction that could be due to obstructed inguinal hernia. So then, even before surgical intervention, we know what's the diagnosis. Right? It's very important, very, very important to examine the area. Without doing PR, per rectal examination, and the per vaginal examination, you will not be able to complete your examination process. So please be kind enough to do the per rectal examination and per vaginal examination. Other special signs you have to look for. Some of them are Murphy's signs, Soa's signs, obturator signs, Krause's signs, and so on. I don't think I have time to explain each of these. Yeah, rectal examination I have already mentioned. End of the examination, you can get into the investigation. Before that, you have to give special consideration to certain group of people. Extreme of age, that's small kids and the old people. Because they are not in position to give good history to you. Sometimes you really have to depend on your examination findings, not on the history. Pregnancy. Why does pregnancy? You know, most of the abdominal content will be pushed away, right? Even in appendicitis, sometimes you might get tenderness in the right hypochondriac region. So you might think that patient's having polycystitis, but not that. That is because in the organs are displaced from their normal anatomical posture. Immunodeficiency. The immunodeficiency patients, they might not have some of the signs. Say, as example, fever. Though they have a significant septic focus, they might not have fever. Right. So you might have to give certain consideration in towards this group of people. Right. Having good history and doing good examination, after that we have to get into the investigation. Please remember, please don't depend on the investigation. The younger generation, most of the time, they are dependent on the investigation. The investigation will strengthen our clinical diagnosis, right? I'm not asking you all to just disregard the investigation. We need investigation, but we shouldn't depend. Recently, I got I think 28 years old female patient, came with the right male patient, came with the right iliac fossa pain. Patient didn't have classical appendicitis history, but he had a tenderness. Male patient. So that Male in the sense, gynecology problems are unlikely. Because when we get a female patients, our diagnosis will be little complex. The male patient, twice white cell count normal, twice CRP normal, ultrasound scan, appendix not visualized. But still, I felt that that's appendicitis. So then I discussed with the patient, because I have to discuss with the patient. I can't go without the facts. No inflammatory markers, ultrasounds, imaging is not supporting my diagnosis. But still, I thought that it could be appendicitis. So I discussed with the patient. I said that if you're happy, I will go ahead. I did appendectomy. That was suppurated retrocecal appendix. Suppurated retrocecal appendix. If I would have sent the patient saying that your inflammatory markers normal, ultrasounds, nothing found significantly, patient might come with a ruptured appendix. That is why our clinical diagnosis is much more important than the investigation. Investigation will strengthen your clinical diagnosis. Yeah. The full blood count, 10 to 60% of patients with appendicitis have a normal WBC count. Right? Elevated WBC count detect 53% of severe abdominal pathology. Any abdominal pathology. Abdominal pathology means abdominal some sort of infection. Right? That is why we shouldn't depend on the things. If you have doubt, you go and re-examine. All right? Right. So basically, just to start, always we do inflammatory markers. As inflammatory markers, the famous two inflammatory markers are full blood count and the CRP. So that can be done. If your white cell count is high, you're quite sure that there's some sort of inflammation. Don't think that's an infection. Because you see in pancreatitis, your white cell count will be high. That is not due to the infection. That's due to severe inflammation, right? If somebody having a white cell count high, that's done it. Inflammation is there. That inflammation could be infection. That's a different story. Right. So after that, normally we have to do the other basic investigations such as renal function, which includes serum creatinine and electrolyte, and the liver function if it is indicated. And the pregnancy test should be done in each and every female patients come to you with acute abdomen, irrespective of tubal ligation and any other contraceptive device. Disregard those things. You do the base as a basic investigation urine test, right? The ABG and so on said that depend on the patient condition, not as a routine investigation. Right? I have forgot to include here the UFR must, right? Right. Again, I will tell you, depending on the UFR, you can't decide whether the patient has UTI or not. You see, sometimes the UFR says 2 to 3 pus cell. Is it significant? No. If you have a upper tract infection, UFR may be normal, right? The pus cell will be very high in cystitis and urethritis. But in pyelonephritis, you might not get pus cell. But if you get pus cell, that is rewarding. That's a different story. Just because absence of the pus cell, you can't exclude pyelonephritis. You go by your clinical examination. If the patient is having pain and tenderness in the loin region, it may be with high inflammatory markers. Right. After your basic blood and urine investigation, we can get into the imaging. They're one of the famous that the first line investigation of imaging investigations X-ray. X-ray abdomen, right? Plain film, X-ray abdomen and chest X-ray, right? If you get a upper abdominal pain patient and tenderness is there, patient is very old, say 56 years old patients who is having an arthritis for years and years on NSAID, upper abdominal pain and tender upper abdomen. What do you think? It could be gastric perforation sometime. So they ask for a direct chest X-ray, not the abdominal X-ray, right? So most of the people just go by the abdominal X-ray. Then we have to send the patient back to the radiology department for the chest X-ray, because you can see gas under the diaphragm more precisely in the erect chest, not the erect abdomen. In both erect chest and erect abdomen, you can see the diaphragm, but gas will be more highlighted in the chest X-ray because there's a voltage difference when they are taking the chest X-ray and the abdomen X-ray. Right? Right. So after the plain X-rays, you can go by the ultrasound scan, depending on the patient condition, CT and the other contrast study and so on. Yeah. I will just show you a very nice couple of pictures for abdomen X-ray. The corner one, that one, upper corner, the right one, is a patient with the intestinal obstruction. Right? I think you can see the jejunal loops, right? What are the features of jejunal? There's a thing called valvular conventi. When you see the valvular conventi in the dilated loop, we know that that's a jejunal loop. So then obstruction should be at the distal jejunum or ileal level. If it's an ileal problem, there'll be the thing called lead pipe. Lead pipe is no features, it's like a pipe, no features. If it's a colon, there's a house treasure, right? Right. Anyway, this is a patient with dilated jejunal lobes. The patient's obstruction could be at the distal jejunum or ileal level. This one is a very nice X-ray of volvulus, right? Coffee bean appearance is there, right? If you see that, it's straightforward. You don't have to have any other studies to do diagnosis. It's quite obvious, straightforward volvulus. So you can see gas under the diaphragm in this patient. I didn't go by the abdominal X-ray. I just went by the erect chest X-ray. If the patient is very bad, very ill, if the patient can't stand, then go for a decubitus, lateral decubitus X-ray. Sometimes we may not be able to take the erect abdominal chest X-ray. In that case, go for a lateral decubitus. Turn the patient lateral so that you can see the gas shadows upper part of it. That's a very nice one. See that patient's X-ray, chest X-ray, shows some sort of pneumonic patch, right? Patient might come with upper abdominal pain on the right side, right? So because of these things, and as a basic imaging investigation, you may go for a chest X-ray and the abdominal X-ray. Ultrasound scan is very basic things nowadays. It's a bedside test. You can use ultrasound for diagnosing a lot of the surgical conditions, ruptured aortic aneurysm and ectopic pregnancies and a lot of things, right? So down there, I have highlighted appendicitis. 75 to 90% is sensitive in appendicitis. That is why I am not depending on the ultrasound to diagnose appendicitis. You may need, right? Especially when you get a obese patient, your clinical assessment may not be correct. Then you have to go for the imaging, right? If the patient is having long history, again, it's doubtful because appendicitis is not a long history, it's short history, right? Other thing is female patient. You want to exclude, if you want to exclude the gynecological things, go for a ultrasound scan. Otherwise, you don't have to do the ultrasound scan for each and every patient when you suspect appendicitis, right? Because sensitive is not there. Yeah. The CT scan we can do depending on the patient condition after the basic investigation, but this is not for the bad patient. Other advancing investigation, like you may do a ERCP, MRCP, and laparoscopic examination. All these things can be done in stable patient, not in unstable patient. Yeah. Having said all these things, the basic history, examination, and investigation, you just come to diagnose with the management of the patient. Management in the sense, treatment of the patient. Do we have to give fluid for each and every patient come with acute abdomen? Yes. Why? Most of the patients with acute abdomen, they won't drink and eat. So they are most of the time dehydrated. Why can't we hydrate with the fluid? Hydrate the patient with a white bore cannula, right? All right. The other thing is, but you have to be a little bit concerned. If the patient is heart failure, don't overload it, right? You might kill the patient with your fluid, right? After that, throughout the presentation, I just explained the importance of analgesia. When you get a patient with acute abdomen, please you adequate analgesia, depending on the condition. Sometimes your simple analgesia may not, then go for the opioid. Why can't? Right? Why can't you go for an opioid? Right? We are more reluctant to give opioid. No, right? Only thing is, the people are scared of when you're giving pethidine and morphine respiratory arrest. Right? I think everybody should know if the patient get arrested, respiratory arrested, what to do. Don't call us, right? Straight away go for a naloxone and ARV, and then ask somebody to call us. Otherwise, when you run to the telephone, the game is over. So if you do have, that is why every day your ward sister should check the emergency trolley, see whether the naloxone is available. Right? That's life-saving medication. Right? Most of the time we use opioid in the ward, but most of the time we don't have naloxone in the emergency trolley. Right? Right. So good diagnosis is one of the key things. Antibiotic depending on the patient condition. Right? So any itis may need, but pancreatitis doesn't need IV antibiotic unless there's a necrotizing pancreatitis. So now if somebody says IV antibiotic in pancreatitis as a routine management, so we'll give you negative marks, right? So remember that. But if patients have necrotizing pancreatitis, yes, right? That is because of that, don't try to give antibiotic for each and every itis. Antiemetic. If the patient is having vomiting, just see, depending on that. Again, antiemetic, you have to decide what sort of antiemetic to be given, right? Ondansetron, where does the ondansetron act? It acts on the chemorespiratory trigger, right? So, if the patients have some, they having vomiting due to some the due to stimulation of the trigger zone, you go for ondansetron, right? Metoclopramide, right? Act on the dopamine receptors. It's a prokinetic, but don't give prokinetic for the patients having intestinal obstruction, right? You're worsening the problem, right? Phenergan, right? Again, that will act on acetylcholine, right? So we have to have some basic pharmacology knowledge to decide which sort of antiemetic to start. Okay. NG-tube, again, depends. And the catheterizers, in most of the time, if you want to monitor the patient urine output, you may have to. So after this basic management, you may consult the surgical team, and then we can decide what and what to do. And we have to define the patient diagnosis. Depending on the diagnosis, we have to decide the definitive management or specific management. What does this picture says? When you get a patient with acute abdomen, we shouldn't be very aggressive. In the meantime, we shouldn't be very lethargic. Surgeon should be madhyama pratipada. Right? Shouldn't be very aggressive, then you might go wrong because you are panicked. Your diagnosis may be wrong. If you are lethargic, because by the time you turn towards the patients, the thing's gone. Right? So be on a madhyam pratipada and try to act as soon as possible. Yeah, any questions? I know that normally audience want questions, right? I will ask one question, right? Right, summary. Actually, this is summary. The differential diagnosis of abdominal pain is extensive. Our job is to shortlist the differential diagnosis and come to definitive diagnosis. And history, physical examination, and investigation are the key to come to your diagnosis, right? And then again, I highlighted there laboratory investigation to support you, not to depend on, right? If your diagnosis is not sure, reassess the patient, examine the patient again and again and again, right? That's very important, right? This is my question, right? See whether we can come to the diagnosis within seconds. Presentation. 23 years old female patients came with acute abdomen, acute onset, left lower quadrant pain 2 hours ago. The pain is constant, no radiation, no nausea, no vomiting, or no diarrhea, right? No exacerbating and alleviating factors, no vaginal discharge. She's a female patient. No, patient has no medical problem. He's not on any medication, no non-allergies, right? There's no history of exposure to sexual transmitted disease, and but patient is sexually active. LRNP, last menstrual period 4 weeks ago. Vitals, pulse rate 105 per minute, and the blood pressure 103 by 58, respiratory 20, temperature 37.7. Abdomen examination, tender left lower quadrant with guarding and no rebound tenderness. Pelvic examination, no cervical motion, cervical tenderness on vaginal examination. Left adnexial tenderness noted. Rectal examination, no masses, nothing, not significant. What do you think? These are the challenges. These are the black hole in surgery. Yeah. These are the differential diagnosis. Ectopic pregnancy, ovarian cyst, ovarian abscess, because she had a tenderness on vaginal examination, ovarian torsion. Which one should be on the top of the list? This is sudden onset. Remember, sudden onset, right? That's one clue. Pregnancy test negative, IV fluid was given, and the ultrasounds left ovary with absent blood flow, multiple cyst. It's diagnosed twisted ovary cyst. It's a sudden onset. I told on my presentation, if there's a twisted thing, the pain will be sudden onset one. Yeah. So then pass it to the gynae people. Right? I'm safe, right? So that's one thing. I'll just run through for the interest. Give me one couple of minutes. Yeah, we'll go for the rapid presentation of things. See, 25 years old female, recurrent vomiting, diffuse abdominal pain, patient febrile, dehydrated, and tachycardic. History of diabetic mellitus. Right? I just run through. Give me 5 minutes. I think this will be very interesting, right? So when you get a patient to the OPD, you don't have time. I know that. You can't diagnose, but you can guess it, right? The OPD, the doctor has no time to diagnose because he has only 1 or 2 minutes to see the patient. But you can guess. Healthy, 70 years old male football player. And patients complain left shoulder pain and no reproducible on examination, and light headache, weak, right? Ultrasound free intraperitoneal fluid. Remember, when I was a casualty surgeon at NHSL, once I was called from Castle Street Hospital because they have opened a patient and they want to know whether there's a surgical problem. The history of this patient is the patient presented in the medical ward with low abdominal pain, and she has complained. The patients complain various things, right? You can't take each and everything to be significant, right? Complain some urinary tract symptoms as well, low abdominal pain. And so then thinking that the patients had UTI, patients got admitted to the medical ward. In the medical ward, they have done a scan, and so they have noted free fluid in the abdomen. It's obvious that the female patient, you have to exclude the ectopic. So they refer the patient to the castle, and the castle, they have to cover the patient. So they open for the ectopic, but the ovaries, tubes, everything's normal. So then, as patient had altered blood, they call us because I was on call. And then I went ahead and then I did the laparotomy because I can't assess the abdominal organ with a penis incision. That was a splenic injury, ruptured spleen. And so we took over the patient. After patient recovered, I asked the history. What happened? Did you have any road traffic accident, any trauma? Nothing. Only thing is, this patient had a fall at the well about 2 weeks ago. 2 weeks ago. The splenic fracture might not present all of a sudden sometime. Right? Right. If somebody complains shoulder pain, think that whether the diaphragm is irritating. Right? All right. 60 years old female, nausea, diffuse discomfort starting yesterday. Now worsen right lower quadrant. Abdominal examination, it shouldn't be pain, it should be tender, right? Tender right lower quadrant plus guarding. What do you think? It's obvious, ne? Tender, guarding, right hypochondriac, right lower abdomen. It's a common age. The appendicitis is common between 6 years to 30 years. That doesn't mean that other people won't get it. None of the people are immune for appendicitis. Anybody can get it, but common age is 6 to 30. So this fellow belongs to that. Right. 65 years male, history of hypertension, renal colic, and 3 episodes, low back pain, and now it's new pain, and obese, soft, abdomen soft, no masses palpable. When all patients come with the abdominal pain and the back pain, if the patients are having tachycardia and low blood pressure, think of the possibility of ruptured abdominal aortic canal, right? I think these things are very interesting, I suppose. So I don't want to go ahead, but acute abdomen is really challenging to the surgeon. That's what I can say. Thank you very much for listening.